Welcome to our presentation on the myth of misbehavior. For those of you who are new to the Children's Mental Health Resource Center, my name is Elizabeth Errico. I'm the Executive Director and founder of CMHRC, and our mission is to provide guidance and resources for early identification and management of mood disorders, including bipolar disorder and the newly identified phenotype of bipolar disorder, thermoregulatory sleep dysregulation disorder, which has also been dubbed FOH. Tonight, we will be discussing the myth of misbehavior. For those of you who are mental health professionals and would like to earn continuing education credits for your attendance, please head to our website where you can log in to our portal, take the quiz that is required, and be able to receive continuing education credits through ASWB ACE. I believe my colleague Angela, who is behind the scenes here and ready and willing and able to answer your questions in the Q&A, has put the link to that in the chat. So our learning objectives are to differentiate between voluntary behaviors and involuntary symptoms, to identify ways to differentiate behavior from observable symptoms, to describe biological and physiological influences on behavior, and to give examples of tools for treating mental health disorders. So when we talk about the myth of misbehavior, we are looking to examine how to differentiate behaviors that are willful choices from symptoms of a more serious illness, such as depression or bipolar disorder. And yes, we are going to focus on mood disorders like bipolar disorder because it is an area of expertise for us at our organization. But it's not the only area where this information applies. It is just where we're going to pull many of the examples that we use during the talk. So why exactly did we title this presentation, The Myth of Misbehavior? Because we often hear parents and teachers and other authority figures who live and work with children use words like choose, refused, decided to describe the behaviors that they are witnessing. For example, they will say, to avoid doing the assignment, he chose to be disruptive to the rest of the class. Or she refused to put on her shoes and get her coat on to leave for school. But the truth is that for children who live with mental health disorders, like mood disorders or bipolar, those behaviors are more often than not actually symptoms of a mental health disorder. In most cases, these are involuntary symptoms that the children do not have control over. And this leaves children feeling helpless to manage things that they feel are happening to them and that the folks around them think they are choosing. So accepting this myth that behaviors or misbehaviors, as we characterize them, are intentional choices rather than symptoms harms kids. It harms kids, it harms their parents, it harms their teachers and their mental health care providers. Kids are left feeling blamed, feeling alone, feeling helpless to manage involuntary and overwhelming symptoms that they did not ask to experience. And parents and other adults are left feeling frustrated and oftentimes unempathetic and at a loss about what they're supposed to do in order to make the kids behave. So what we're doing now is we're taking a deep dive into the difference between chosen behaviors and involuntary symptoms. But first, we want to address the obvious, that there are questions and controversy over the idea of behavior problems and how to effectively address them. These myths exist in part because expectations of parents, children, and parenting styles have historically revolved around getting children to behave, also known as follow instructions or do what they're told. And there's a fear that children or teens who live with mental illnesses will somehow become emotionally or behaviorally stuck and wrap their entire identity around the fact that they have a mental illness. There are some real questions and concerns that we hear over and over again from parents, grandparents, friends, extended families, school administrators, teachers, doctors, nurses. I mean, you name it. Basically, anyone who is genuinely concerned about the child who is struggling will at some point ask one of these questions. How do you know this isn't malicious and intentional behavior? How do you know the child isn't manipulating you? Children need to learn boundaries and consequences because they're going to grow up and live in the real world. This parent needs some parenting classes to learn how to better parent their child. Or from parent, I don't want my child using bipolar, depression, anxiety as an excuse and their medicine as some kind of crutch. There are very real, valid concerns behind these questions. And if we distill it down, what we're really getting at is the question of how is this child, who obviously has significant difficulties in functioning, how is this child going to be able to become a responsible, functional adult? And it's hard to imagine a child who has destructive rages when they're told no, they can't play on the computer right now, or a teenager who screams profanity at their parents while refusing to go to school will one day be able to drive a car or pay bills and graduate from school and live independently. Parents are afraid for their child's future. And sometimes parents even acknowledge that they're afraid for their own safety due to their child's episodic irritability and aggression that often accompanies mood disorders in pediatric population. So these questions and comments arise out of parents' concern for their children, as well as for themselves and the rest of their family. So with this acknowledged at the outset, we're going to start by looking at what the word behavior really means. And a behavior is the way in which one conducts oneself, which then leads us to ask the next question, which is what does conduct mean? And the definition of conduct is to cause oneself to act or behave in a particular and especially controlled manner. As a result, most people think of behaviors as actions that the child or adolescent is aware of and controls. You see, we assume that the child or teen has control over how they respond to their environment. We assume that the child is capable of controlling and deciding upon which response based on their internal or external stimuli they're going to choose to give. These assumptions encourage us to then interpret what we are observing as willful, intentional, chosen acts that are then described as manipulative, defiant, oppositional, or attention seeking. These interpretations add to the observed behavior an assumed intent, and it can inflame the adults into feeling frustration and anger and even sometimes fear. But what if there's a different way to understand what we're observing? And what if there's a different way to help a child or a teen struggling with extreme dysregulation? The good news is that there are ways to assist children and adolescents living with this dysregulation and mood disruptions. And the key is first, we have to recognize that these behaviors may actually be symptoms of a mental health disorder or mental illness, making them beyond the child's control. Or if they're not symptoms of a mental health disorder, we have to acknowledge that they are still communication from the child or teen as to the damaged state of well-being and the fact that they need help. Put in a simpler way, all behaviors, whether symptoms or not, are communication from the child or teen about how they're doing and what they need. So now that we've looked at the definition of behavior, let's look at the word symptom. According to the Journal of the American Medical Association, a symptom is a manifestation of the disease that is apparent to the patient himself. A symptom is something that the client or patient experiences themselves. A sign, on the other hand, is some sort of objective evidence, either witnessed by an observer, that can be a parent or a teacher or a therapist or anyone who is around the child. It is witnessed by an observer or documented through medical findings such as lab work, scans, physical exams, and the like. However, clients, patients, don't always have an awareness that they're experiencing symptoms of a serious illness. While this might be especially true for children and teens, if we're being honest with ourselves, though, we can admit that everyone at times lacks awareness that they're experiencing the symptom of an illness. We count on others to share observations, to bring those symptoms into our awareness. In the case of children and teens, it's most often that the adults in their lives are recognized as the responsible observers and the reporters of those signs. So signs are a manifestation of disease that the physician or therapist or observer perceives. It is a sign, is an objective evidence that is obtained through observation or detected through medical findings. This may seem like a dated definition, but it does remain the standard that is used today. And these two terms sort of acknowledge and identify that some disease manifestations are seen by others and some disease manifestations aren't. But mental health professionals use the term symptoms almost universally to include both symptoms and signs. Both what the client is experiencing as well as what the observer is reporting, both get lumped under the terminology of symptom. So for the purpose of this seminar, we are using this universal terminology of symptoms as defining both symptoms and signs for the sake of simplicity. Now, we have to remember that in order for symptoms to be classified as a disorder in the Diagnostic and Statistical Manual of Mental Disorders, the disturbance has to meet two fundamental criteria. And the first is that the disturbance has to be an obstacle to daily living, that it is a disturbance that is sufficiently severe to cause marked impairment in social, occupational, interpersonal, or intrapersonal functioning. In children and teens, an occupational setting is generally accepted to mean school. This means if a person is experiencing marked impairment in multiple settings to the degree that they are not successfully able to function, it is likely that we are looking at an illness, not purposeful behavior designed to be manipulative, attention-seeking, defiant, or controlling. So for example, if the child is experiencing behavior in quotes, problems at school and at home, then likely what we are looking at is a disorder, not just a chosen behavior. The second criteria is, does the disturbance cause subjective distress for the patient? When overwhelmed by involuntary symptoms, the effect those symptoms have on the individual, as well as on those around them, can be extremely distressing for the patient. For children and teens whose fundamental safety is based on being accepted and cared for by others, they exhibit these behaviors that then alienate them from those they count on for support. And that is extremely distressing, especially so when it is some sort of involuntary symptom. Parents routinely describe their children as being absent or not there when extreme behaviors are occurring. And children and teens report feelings of fear, isolation, self-doubt, and self-hatred as a result of some of their involuntary symptoms. Children as young as 5 talk about experiencing this. These are some self-reports from children and teens who live with mood disorders. They share things such as saying that they feel as though they are trapped inside of a monster, inside of a cage where they don't have control over themselves. They talk about looking like themselves on the outside, but on the inside, feeling as though they're no longer there, feeling as though they have no control, and when they are expected to have control, feeling helpless and hopeless, that there is nothing that they can do to prevent it from happening again. We're going to move on now to our second learning objective, which is to identify ways to differentiate behavior from observable symptoms. So, Dr. Jerome Wakefield, psychologist with the New York University School of Medicine and the Psychoanalytic Association of New York, wrote in 2015 that to be a disorder, symptoms must be caused by a dysfunction. Disorder inherently involves both harmful symptoms tracked by severity and dysfunction, an inferred failure of some psychological mechanism to perform its biological function. Put another way, when a person lives with a mood disorder, what we observe are symptoms of a biological phenomenon and the body's physiological response that disrupts daily functioning and causes subjective distress. This is one of the reasons why we refer to disorders like mood disorders as biologically based disorders. They are the manifestations of a disrupted biological function that is resulting in psychological symptoms that are perceived by those around them as behavioral. Now, what can make this confusing for many clinicians is that there are significant flaws with the DSM model, namely that it explicitly and intentionally does not address biological causes or really any causes at all. The DSM has been widely criticized for over-pathologizing human behaviors, making normal behavioral responses a medical issue. And another area of concern is the emphasis on medication management without a real understanding as to the biological origins of symptoms. It has been argued that the classification system should be based on understanding brain-based biology, and that all of this, the pathologizing of normal human experiences and behavioral responses, intentionally not addressing biological causes, and emphasizing medication management leads to debate over what exactly then is a disorder versus a typical human behavior. In the meantime, it offers very little to no real insight about targeted interventions for mental illnesses that are geared towards specific physiological responses and ultimately addressing the biological causes of the symptoms. The DSM is undergoing revision yet again and moving to a dynamic model. When this comes out, the creators of the DSM at the American Psychological Association are talking about increasing the focus on causes, which will help with targeted treatments designed to address the causes rather than simply address the symptoms. But for now, this is the system that we are left with prior to understanding what those causes may be. There are also certain basic parameters to the diagnostic process, which include using proven diagnostic assessments, extended clinical interviews, reviews of historical information, not only about the individual patient, but about their family history with mental illness and physical illness. There's the rigorous differential diagnosis process that we need to go through, and interdisciplinary consultation, collaborative treatment team planning, especially when a child has a therapist, a pediatrician, a school counselor, an occupational therapist at school, an occupational therapist in the community. All of these different folks who are working together to help the child, but may not be actually interacting with one another. Putting these things together, from using proven assessments to interviews to historical data to differential diagnoses, helps us understand what we're seeing and how we can address it. On a more fundamental level, though, parents, teachers, coaches, friends, mental health care providers can always look back to the two most basic criteria for a disorder and its symptoms. Does it obstruct daily functioning? And does it cause subjective distress? If both of these are happening, then you've got symptoms, not behaviors to address. It is the symptom that is an obstacle to daily functioning, not the behavior, not the child. It is the symptom that is causing subjective distress. Again, not the behavior, not the child. So you may ask yourself, why does this distinction matter? It matters because the word behavior forces us to think in terms of choice and intention, because that is inherently a part of the definition of the word. The interventions used for behaviors are about molding and shaping those choices and intentions to be more aligned with external expectations. That is a system ultimately designed to fail the child or teen who lives with a mood disorder or some other form of mental health disorder over which they do not have any control. When we think in terms of symptoms, we are able to recognize that the symptom is the obstacle the child is trying to overcome, that it is causing that child's subjective distress, and we truly see them as a person who is struggling and needs help first and foremost. So it is our position that there is also an urgent need to identify symptoms as soon as possible, rather than to dismiss them as purposeful behaviors. Early identification and intervention helps us to reach better outcomes. According to Marco Colizzi of the International Journal of Mental Health Systems, promotion, prevention, and early intervention strategies may produce the greatest impact on people's health and well-being. Screening strategies and early detection interventions may allow for more effective healthcare pathways by taking action long before health problems worsen or by preventing their onset. In short, early accurate diagnosis followed by early effective intervention with targeted treatments, is the best tool that we have to creating long-term successful outcomes. Our third learning objective is to describe biological and physiological influences on behavior. As clinicians, it is our job to effectively identify symptoms of mental illness and to be able to distinguish them from, quote, normal human behaviors. Consistent use of a rigorous differential diagnosis process is essential to successfully determining this difference, especially when it comes to children and teens. This differential diagnosis, the process allows us to include really solid best practices, or what David Miklovitz from UCLA describes as the gold standard practices, utilizing skills and assessments and tools that will help us differentiate developmentally appropriate behaviors from serious mental illness. This is one of the biggest controversies that continues to exist in the diagnosing of bipolar disorder. Too many people will continue to say that it is too difficult to differentiate symptoms of bipolar disorder from normal and expected developmental stages. However, when we go back and look at, are these behaviors causing subjective distress? Are they an obstacle to daily functioning? We are able to quickly and easily understand that we are looking at an illness and not an expected behavior. Now, in order to be able to engage in this complicated differential diagnosis process, which is going to help us rule in or rule out many different diagnoses, we have to keep up with current research. This guides us on how to target interventions and treatments to give us a high degree of confidence that they will be effective. When we recognize symptoms as symptoms and not behavioral problems, we can then turn our attention to understanding the underlying biological influences and the physiological structures that are involved. So, what exactly are some of these structures that are involved in symptom presentation when we're talking about mood disorders in childhood and then adolescence? So, in order to examine that question, we're going to take a look at a little bit of information about the limbic system. The limbic system's role. There are three structures of the limbic system that we're going to talk about right now: the amygdala, the hypothalamus, and the hippocampus. These three structures in the limbic system are involved with regulating the release of neurotransmitters that communicate with other parts of the brain and of the body. The limbic system plays a significant role in coordinating how the brain and body respond to both internal and external stimuli, and then in the activation of that fight, flight, freeze response. So examples of biological processes that the limbic system influences include temperature regulation in the body, sleep-wake cycles, appetite, and interpretation of auditory, tactile, and visual processing. When there is a dysregulation or dysfunction in the limbic system, there are some observable biological symptoms that can be observed. Symptoms that indicate a dysregulated limbic system can include the following. They reflect areas such as sleep and appetite disruptions, irritability, aggression, anxiety, fears, inattention, hyperfocus, and tantrums, amongst others. So now we're going to look at a list of common symptoms of mood disorders in children. And you'll see that the lists are basically identical. This means that the biological symptoms of a dysfunctioning limbic system are the same signs and symptoms observed in mood disorders. There are many professionals and parents who will say, but these things happen in a lot of kids who don't live with mental illness. And yes, that is true to some degree. We all have limbic system dysregulation from time to time, which is why it is important not to jump to conclusions and pathologize normal human behaviors. But at the same time, it is also equally important that we not dismiss something that does have a pathological basis as a normal human experience when we don't know whether or not that is the case. We can find some clarity on this, however, by determining if these issues are present in developmentally normal ways or not by looking back to the DSM to once again those two things that we identified. Is the disturbance an obstacle to daily living? And does the disturbance cause subjective distress for the patient? Whenever we come back to this is helping us understand whether we are looking at developmentally expected behaviors or symptoms of a mental health disorder. Now combine this differentiation with an understanding that the limbic system functions and disruptions in those functions can create a biological root or cause to those symptoms seen in depression, bipolar disorder, anxiety disorders, ADHD, autism, and PTSD, and it changes our understanding of the quote behaviors that we're observing, and we can see that an inability to sleep at night is not a willful refusal to follow instructions to go to bed, but a disruption in the sleep wake cycle. A defensive reaction or aggressive response to being asked to do homework can be understood as a misfiring of the fight or flight or freeze response and not a choice to be oppositional. A dislike of music class, gym class, or lunchtime at school can be understood as a disruption in the interpretation of auditory, tactile, olfactory, or visual stimuli. It's not a decision to be disruptive in class, to get attention, or to avoid work. But misunderstanding or underestimating the influence of these biological processes on symptom presentation can lead to misdiagnosis or complete dismissal of the mental health condition and attribution to it as expected developmental behaviors. You can learn more about misdiagnosis and how it plays a role in the identification of symptoms of bipolar disorder, specifically through many of the different seminars, webinars, and materials that we make available because of the generalized confusion specific to bipolar disorder in children and in adolescents. Now, a second important biological and physiological influence stems from the simple fact that the human brain is one of the most energy demanding organs. The limbic system's role in regulation and coordination of the brain and body utilizes more synaptic activity, which requires more energy, than other parts of the brain. According to Harvard Medical School, the brain uses over half of all of the glucose that is in the body. In recent years, researchers around the world have begun to think of unipolar depression and bipolar depression as mitochondrial diseases, or put another way, energy disorders, rather than psychiatric conditions. It would make sense if bipolar disorder is considered an energy disorder, that the areas of the brain that require the most energy, like the limbic system, are significantly impacted, and that they might become either over or underactive as a result of these energy fluctuations. There's overwhelming new evidence that suggests that metabolic disease has a significant role in psychiatric illnesses like bipolar disorder. Or to put it another way, bipolar disorder is moving towards being considered a medical disorder with a biological cause. Now, this is also especially true for the phenotype of bipolar disorder that has recently been recognized and that researchers dubbed FOH, because many of its symptoms are triggered by biological causes associated with temperature dysregulation, which is also controlled by the limbic system. Our final learning objective for tonight is to give examples of tools for treating mental health disorders while understanding that the symptoms are being caused by some underlying biological or physiological condition that we have perhaps not yet been able to identify. So, research on metabolic psychiatry is interesting, exciting, and going on all over the world. But it is truly a major paradigm shift. And it can be very challenging to accept the first time or even the third, fifth, or 10th time that you hear about it. We encourage anybody who's curious to get more information on metabolic disease and its role in mood disorders to seek out resources that are readily available, like Metabolic Mind, which is a nonprofit that is transforming the study and treatment of mental disorders by exploring the connection between metabolism and brain health. You can browse their website, catch their podcasts on whatever streaming platform you use, watch them on YouTube. They have a lot of free resources with exciting information on current studies and ongoing research. We ourselves have worked with Metabolic Mind. We have free resources available to bring this information to people, including information on the use of ketogenic therapy or a keto diet, on the treatment of mental health disorders. And we also have an in-depth series on the limbic system. Okay, so we should really pause here to address another myth or misconception that is echoed in comments that we hear so often from parents and teachers and mental health providers and other authority figures. And that is, even with a diagnosis, it doesn't seem responsible to reinforce the idea that it is okay to use mental illness as an excuse. Parents and teachers share their belief that in the real world, it doesn't care about a person's mental illness or behavior or mental health diagnosis or what is causing their symptoms. What they care about is the observable behavior. And that if consequences or punishments, because consequences is really just a new word for punishment, aren't given in childhood and adolescence, then how will the child ever learn how to stop these behaviors? But when we really understand and accept the reality that mental illness has a biological cause, then we will flip the whole mental health model on its head and acknowledge that symptoms are not purposeful behaviors that can be molded with consequences and punishments, that symptoms are a result of a medical condition, which, frankly, they're not any different from other chronic medical conditions such as asthma, diabetes, or epilepsy. So just as punishments or consequences are not going to stop asthma attacks or correct low blood sugar or stop a seizure from happening, it won't stop symptoms of mental illness from occurring, because the triggers for those symptoms are rooted in brain chemistry and physiology. In the case of mood disorders, punishments can actually propel the person into further crisis because they can't meet expected metrics and they can't make change. Rewards at the same time are likewise unhelpful, because for many living with mood disorders, especially children and teens, they know the involuntary symptoms are going to occur. They're going to prevent them from meeting the expectations and the goals that are imposed upon them by others. And it sets them up for failure. It makes them feel both hopeless and helpless, exacerbating the mood disorder symptoms. Now, bargaining if you do X, then you can have Y privileges. This system is often seen. It's used at home, it's used in school, it's used by therapists. It is not, I hate to tell you, a strategy that has therapeutic value for children who live with mood disorders. It is a strategy that, quite frankly, simply rarely works. Pairing a desired outcome with an impossible task will likely elicit the exact opposite outcome than was desired. When bargaining fails, we know that the expected task was beyond the child's control. So we can remember, if punishment, rewards, and bargaining work well, and behaviors are able to be resolved without other interventions, then that's a major clue that the behavior likely wasn't the result of a symptom of a mood disorder or any other persistent mental illness. Because you can't bargain with biology. If it worked, then there's no biological underpinning there because you can't reason with your biology. We say this over and over again. But for those of us who are new to our work, it's incredibly important to communicate and make clear that a dysregulated child or teen who is not able to function in their environment is experiencing a medical crisis. We're not going to require a child with asthma to earn the right to access their inhaler. We do not expect a child with diabetes who's experiencing low blood pressure to resolve the problem using coping skills. We're not going to suspend a student who hits their teacher while having a seizure. We fully recognize in these cases that they are experiencing an involuntary medical crisis and are in need of immediate attention to address their immediate need. So how do we do this? How do we create equity between medical and psychiatric conditions? How do we recognize that psychiatric conditions are not rooted in some abstract concept of the mind over which the individual has ultimate control, but that these disorders are rooted in biological foundations and that we need to move away from punishment and reward systems? Well, there are three primary tools that parents and patients with significant mental health challenges need to use in order to achieve and maintain stability. We refer to them as a three-legged stool of treatment because, like a three-legged stool, if one of them is missing, the stool will eventually fall over. And without all three of these pillars, successful treatment can fall apart very quickly. And these three treatment tools are medication, therapy, and lifestyle interventions. Now, we are going to acknowledge right off the bat that not everybody necessarily needs medication for mental health disorders, and not everybody necessarily wants to take medication. That is an individual choice made between the individual patient, their family, and their provider. However, many of the biologically based illnesses with physiological symptoms, like the ones that we've been talking about, medication can be the game changer. And while no one should be forced to take medications, they also should not be prevented from taking the gold standard medications for the diagnoses that they have. They should receive clear, unbiased information in order to make a truly informed decision about whether or not they want to take medication or give it to their children. So with that in mind, there are several objections to using medications that we hear from families and providers that we'd like to address. One is that medications have too many side effects and can be potentially harmful long-term. The other is that they are a crutch that will prevent the individual from learning how to cope, and that it won't solve everything. In each case, these concerns have merit. But when we compare it to the risks associated with a careful, attentive, and slow titration of a proven medication, we can see that the benefits outweigh the risks associated with not treating the disorder. So, what do we mean by that? Statistics show us that 20 to 60% of the 6 million people estimated to have bipolar disorder in the United States attempt to end their life. Nearly 20% die by suicide. 40% lifetime prevalence rates of developing substance abuse disorders exist in those with bipolar 1, and 20% lifetime prevalence rates of developing substance abuse disorders are present in bipolar 2. Nearly a third of children who have bipolar disorder attempt suicide before the age of 14. Given these serious statistics, medication, we present for your consideration that given these statistics, medication isn't a crutch. It is an essential part of managing the potentially devastating consequences of a serious mental health condition. Becoming aware of these and other statistics is an integral part of a family's ability to make a truly informed decision of when and how to use medication. And it is an integral part of the psychoeducation that is the responsibility of the mental and physical health care providers. Now, once medication is being used, it is extremely important for parents and families to be able to track the effectiveness of the medication, its dose changes, the frequency with which it's taken, and the consistency with which it's taken. There's a tool to track mood, symptoms, and medications that we use. There are many out there that you can have access to. We use one that was designed specifically for members of our community who are parents who have children with mood disorders and need to be able to record observable signs of their child's subjective distress. Because oftentimes with children and teens, asking them to report on their subjective experience can, in fact, trigger symptoms. And so we find that many apps that look for the subjective individual patient experience are challenging for children and teens. And instead, we use one that was designed to allow parents to observe. Now, the next leg of that stool is therapy, the next pillar of that treatment matrix. So therapy can include everything from psychotherapy to speech and language therapy, occupational therapy, physical therapy, and different individuals have different therapeutic needs. And if we think of therapy just in terms of psychological therapy, we may be limiting the options and opportunities for success for that individual patient. For example, a child who is in the throes of active mood disorder symptoms, who's constantly triggered into a state of fight, flight, freeze, is likely going to be unable to engage in many, if not most, of the cognitive or behavioral therapies that are so popular with psychotherapists. Whatever skills that they may learn in the therapy become inaccessible to them when they become dysregulated by those involuntary symptoms. And much like an oven that works beautifully when it's plugged in, but won't cook your food when it's unplugged, during those experiences of dysregulation, their brain is essentially unplugged, unable to access these skills and tools that they have been taught and have been able in times of regulation to repeat back and discuss with their therapist, teacher, or other adults. But this child may actually benefit greatly from occupational therapy that helps them learn how to identify environmental challenges that might trigger them, that help them identify physical and physiological changes that happen with them, that they become able to identify as precursors to those involuntary symptoms. These types of therapies and identifications can set them up for success in terms of identifying what their needs are and how to ask for them before they become dysregulated. When psychotherapy is engaged, it is important to remember that the families that you're seeing whose children have serious mood disorders and their teenagers have serious mood disorders have likely already been to several other therapists and haven't found success, which is why they are now in your office. The National Institutes of Mental Health estimate that the average treatment onset delay for a child with mental health disorders is 10 years, which means whether you are finding these people at year 2 or year 10, they have already been through this with another therapist. This means that as mental health providers, we have to validate the family's experience and listen first rather than jump to any specific treatment plan or model just because it's what we're familiar with. Chances are, as I said, you're not the first provider to suggest a sticker chart for rewards or to suggest some form of token economy. These families know from their experience that that is not going to work for their child. If it did work, they wouldn't be on their second, third, or fourth provider. It's really hard, though, for some providers to understand that part of our jobs is to gently and mindfully prove to our patients over and over and over again that we have the knowledge, insight, and skill set to assist families whose children or teenagers live with a mood disorder, and that they're not just going to get from us the same thing that they've already gotten from everybody else that they already know doesn't work. As I mentioned earlier, the average treatment onset delay is 10 years. That is 10 years from the first contact with a general medical doctor and 11 years until the first contact with a psychiatrist. This means that parents and children have been living with ongoing symptoms, living with involuntary symptoms, living with dysregulation for years. We know that many, both children and parents, are judged and even blamed for their symptoms of these serious mood disorders. Families have experienced shame, blame from extended family, from professionals, from friends, from community members, from teachers and schools. And it is typically going to take a very long time to earn their trust. And the rapport building process can take longer than you may expect. It can stretch up to a year or more because telling them that we are trustworthy doesn't make them trust us. Their experience of us as trustworthy is what makes them trust us. And that can only occur over time. Now, once that rapport is successfully built, it is important to remember that traditional cognitive and behavioral therapeutic approaches are not going to be initially effective in treatment strategies for children and adolescents living with early onset bipolar or early onset major depression. And it sounds controversial that many providers have been trained in these modalities and they push back on this assertion, but it really does remain the truth. These children, once they become regulated and stabilize, these cognitive behavioral treatments may work. They become effective because that brain is online, that brain is plugged in and can access its learning during those periods of dysregulation. But in the beginning, that's not going to happen. The frontal lobe, the executive functioning powers, can't be accessed when the limbic system takes over and drowns it out. It is critical that we acknowledge and address these symptoms as biological and medical crisis that they are, and achieve symptom remission before we start teaching coping skills. For example, you don't get a patient with a broken leg up on their feet, walking, until you've been able to assess the damage from the break and, in many cases, perform surgery. So let's get these children stabilized and de-escalated and regulated before we start asking them to access portions of their brain that are offline during dysregulation. To achieve this, we highly encourage a Rogerian or person-centered approach. When a child or adolescent with a mood disorder first enters into therapy, the primary focus needs to be on acknowledging their struggles, validating that they have an illness with involuntary symptoms, providing education for them and their families on the illness, providing resources, and developing those feelings of trust and safety. Many children living with mood disorders do not feel well liked or even wanted in many, if not all, of the spaces that they exist in. Having a welcoming place with a welcoming person where they feel accepted and validated for who they are without having to prove themselves in some way is a critical first step in healing and in recovery. And it can be achieved by demonstrating Carl Rogers' concept of unconditional positive regard. This fundamental Rogerian principle may not seem very concrete, and it's certainly not a formularized approach that is, popular with many of the current therapeutic paradigms. But the truth is that many children living with a mental illness have not felt understood or safe in life or in therapy, nor have they had appropriate pharmacological treatment due to those delays in accessing an accurate diagnosis. So providing them with that unconditional positive regard will be the foundation of anything and everything you are able to accomplish over the course of the therapeutic relationship. Now, lifestyle interventions. These are the crucial third leg of an effective treatment plan, that third leg of the stool. Everything from sleep hygiene, diet and nutrition, exercise, meditation, social interactions, intellectual stimulation, and cooling strategies can play integral roles in achieving and maintaining both stability and a high quality of life. One patient that I know talks about the fact that every day there are 6 things that they focus on. They focus on their sleep, they focus on what they eat, they focus on getting exercise, they focus on engaging in the practice of meditation, they focus on making sure they are having meaningful communication and relationships, and that they have a sense of purpose. Now, there's absolutely going to be certain through lines and consistency from person to person in terms of certain lifestyle interventions. For example, sleep hygiene, reducing blue light exposure, establishing a bedtime routine, having a set time that you go to bed and wake up every single day that aligns with the light and dark in the region where you live, promotes stability for anybody living with a mental illness. It also promotes stability for anyone or any living creature at all. Those circadian rhythms are extremely important. Additionally, exercise of some kind every day, a regular walking routine, will also promote good mental health and stability in just about anyone. But other aspects will vary from person to person. For example, do you prefer to go to bed at midnight and wake up at 8 a.m. or go to bed at 10 p.m. and wake up at 6 a.m.? Do you like to go for a long run every day or swim laps in a pool or practice yoga? Lifestyle interventions can be and should be personalized around these fundamental categories to match the individual's needs, personality, and likes and dislikes, while also providing structure and support for long-term symptom management. But we would be remiss not to mention that when it comes to children and adolescents, there is a tendency for parents and caregivers to approach treatment, and even treatment providers sometimes to approach treatment as the way to fix the child or to end the problems that their illnesses cause. So, the most important lifestyle intervention that has the biggest impact on treatment actually stems from letting go of the idea that there's a fix or an end to the illness. This isn't, we should clarify, suggesting that we have a hopeless attitude. Far from it. In fact, it comes from the fact that we recognize that by focusing on management rather than cure, teaches the child they have value as a person, that this illness is not the sum total of who they are, that this illness is not a blight on who they are, that they have value and that they are not the sum total of their symptoms of their illness, and that their experience doesn't have to be erased in order for them to be able to improve. Much of this is communicated through the behavior of parents, caregivers, teachers, and other authority figures, and it requires a radical paradigm shift in the way we approach parenting a child or teen who has a mental illness. The truth is that daily experiences, values, culture, and sexual identity all affect how we perceive mental health and mental illness. Individuals have to feel empowered to advocate for their needs and the needs of their loved ones. The provider must create a safe space that will encourage this kind of communication, build trust, and improve outcomes by continuing to educate and incorporate cultural needs into treatment. Language barriers and limited availability of service providers who are culturally appropriate can prevent individuals from getting effective and timely care. For instance, Asian Americans are least likely to receive mental health treatment, with 20.8% of Asian adults with mental illnesses actually receiving treatment. Asian Americans also report that they are far less likely to seek out care out of fear of others finding out. Similarly, only 1 in 3 Black Americans with a mental illness receive treatment. And if that treatment is received, they are less likely to receive guideline consistent care and less likely to be included in research studies. This community is also more likely to experience socioeconomic disparities, which limits availability to resources and increases the likelihood of mental illness. Further, many Black Americans, especially older adults, view mental illness as a sign of personal weakness. This thought pattern perpetuates shame and decreases the likelihood that they will seek appropriate treatment. Hispanic young adults, ages 8 to 25, are also less likely than their white counterparts to receive treatment. Barriers such as language, legal status, lack of insurance, immigration status, and poverty contribute to only 35.1% of Latino adults with mental illness receiving treatment, a significant disparity from the average 46.2% of the US average. Finally, LGBTQ plus adults are more than twice as likely, and transgender are 4 times as likely as heterosexual or cisgendered adults to experience mental health crises. They experience harassment, they experience a lack of access to appropriate care, and stigma, all of which create obstacles to appropriate and effective diagnosis and treatment of mental health conditions. In our years of work with parents and families, We have seen over and over again that parents very often recognize that their child lives with a mood disorder long before their providers come to that same conclusion. What families are searching for is a professional who understands what mood disorders look like in children, understands that the behaviors and symptoms aren't necessarily going to present the same way that they present in adults. They are going to be seeking out people who realize that behaviors and symptoms are not the same thing and are willing to partner with parents, who will advocate with parents for the children that are in their care, and who are willing to do all of this in culturally sensitive ways. Together with families, we can become the providers that the children need. These slides have all of the sources that were cited during the creation of this presentation. We're now going to turn off the screen share, and I'm going to invite my colleague Angela to join me on screen, where she is going to help me go through some of the questions that came through in the chat during the course of our seminar. Hi, Angela.
Hey, Elizabeth, thank you so much. This is one of my favorite topics. I think it's so important for parents and for providers. And we've seen some activity in the chat that just shows how important that is. And one of the first questions that came up that I think is probably on a lot of people's minds, and not everybody wrote it down, was how come then some children can hold it together at school and deal with their symptoms, but then they get home and they lose control?
That's an excellent question. In some ways, people are asking that, and I like to sort of get at the root cause of the question, which is that they're using that as a way of questioning, is this a disorder or not, right? The thing is, it very often comes down to two things for kids who have mood disorders. One is stamina. We all have a level of energy that's influenced based on how we slept, when the last time we ate, how healthy the food was, you know, all kinds of things that gives us a finite amount of energy on a daily basis that we get to use to do all of the things. And we all know what it's like when we're tired and hungry, that it's going to be more challenging for us to be able to maintain regulation in our moods and subsequently in our ability to handle symptomatic behavior. Children who have mood disorders, teens who have mood disorders, they have more demands on their stamina than someone who doesn't have one of those disorders. And so it's taking more energy for them to be able to go through the normal activities of their day. And so they are running out of stamina earlier in the day than someone who doesn't have a mood disorder. And so they may have enough energy to force regulation during the morning at school, but not have it for the afternoon at school. Or they might have it to be able to get through the day at school, but not be able to get through until bedtime. And so there is this stamina leak, if you will, that is obstructing their ability to maintain whatever regulation they are able to enforce. And I'll also add that usually as stamina decreases, involuntary symptoms increase.
That was really helpful. Another piece that I think is really helpful that we have said time and again is you can't punish, bargain, barter, or reward away biology. And I think that in the vein of trying to decipher, is this a symptom? Is this a behavior? and really utilizing that thought process of, like, did I implement a sticker chart and it worked? Um, that's never going to work for a symptom, as you discussed. And so I think that that paradigm shift is really so important in helping lead children to stability. Someone else asked, what are some of the ways to support children with other underlying health conditions? And I think that they meant that can't keep their nervous system out of fight or flight. So if we
So
have like comorbid conditions going on, what are some ways that we can help those children?
anything that reduces inflammation in the brain and in the body is going to help when someone becomes dysregulated in their nervous system. So that may be something as simple as not using um, artificial light, allowing the person to be in a soothing situation sensorially, that they were reducing the amount of visual, tactile stimulation that they're exposed to. There's a characteristic that is often the case with kids who have bipolar disorder in particular, which is that they often don't want to wear clothes. Parents will routinely report that their child gets in the car from school and will start peeling off their socks and their shoes and their shirt and their sweater and all the rest. And you get home and you've got a 7-year-old who's in his underpants. Um, Sometimes that's a symptom of a temperature dysregulation issue that's associated with fear of harm. And sometimes it's that being touched by their clothing is starting to become sensorily overloading. So, recognizing that that's not difficult behavior, recognizing that the child needs to have their nervous system soothed, means that that's not the time to be introducing new things, to be introducing harsh things, to be introducing things that are a challenge to them sensorily, so that they are able to engage in calming experiences.
That's really important. Excuse me, that's really important to recognize. And I think it segues nicely into the question about therapy modalities. We discussed that when a child is dysregulated, those modalities, they're just not going to stick. And someone specifically asked that they're interested in the overlap of children who have mood disorders and autism, because many autism therapies focus on rewards and consequences. And that can sometimes help with the autism piece, but obviously is contraindicated for the mood disorder piece. So how do you know what therapy is right for what child?
That's a really good but very complicated question. And what I would say is that as long as we are trying to figure it out based on diagnosis rather than on underlying cause, we are at a disadvantage because it's not dissimilar to, well, I have a sore throat and I'm exhausted, but I don't know whether I have the flu, a cold, or strep throat, right? Until we have a test that tells us whether it's the flu, a cold, or strep throat, we don't really know what treatment to use because they all require different things. With a cold, there's not much you can do. With the flu, you can get on an antiviral quickly. With the strep throat, you can get on an antibiotic. But if you have a cold, taking an antibiotic doesn't do any good. So we really have to reshape our understanding of what we're doing and accept this paradigm shift that mental health disorders are physical health challenges, and we haven't figured out what all of the biological mechanisms are. Luckily, with mood disorders like depression, like bipolar, what we're learning rapidly is, as I mentioned in the presentation, that there are mitochondrial effects and dysfunctions that are going on in people who have these mood disorders, and that addressing that mitochondrial dysfunction is going to help resolve symptoms. And so things like ketogenic therapy and other metabolic interventions are helping people who have these disorders. And what we're learning is that when a child who has bipolar disorder is treated using ketogenic therapy, it's helping to resolve some of their autism symptoms. And so now we're realizing that actually some of these disorders or some of these treatments are actually what we call transdiagnostic treatments, and that they work on the underlying causes rather than working to simply alleviate a symptom. And so when we really truly embrace that, therapeutic interventions cease to be about singular diagnoses and become about what is actually causing improved functionality in this person, what is causing improved quality of life in this person, what is causing symptoms to decrease. And if it's one particular type of therapy, then great, that works for that person. But it's that individualized attention and care that has to go into determining what's going to work, because we can't just slap the same band aid on every diagnosis just because it worked for the last person who had that diagnosis.
That individualization, I think, across the board is really a critical piece to finding stability. There's lots of chatter in the Q&A about the comorbidity of autism and
Mm.
neurodivergence and mood disorders. And so, you know, someone was asking what is some ways to support a parent with a child that has the diagnosis of both autism and behavior aside from, they said, aside from ABA therapy. And I think that you just touched that nicely, is some of those lifestyle interventions, when we implement them, we see some of those symptoms decrease. And so it's, again, a lot less about the diagnosis as much as it is finding a way of life that's more functional and productive. Um, in that vein, someone asked that they've observed students with diagnosis of autism and anxiety have daily learning gaps. So, for instance, they had a math lesson but couldn't learn. And then hours later, after calming down or having a meltdown, they could complete the assignment. Can you talk a little bit about that and how that fits into kind of the symptom um, profile that you're discussing?
Yes. So with mood disorders, they are by their very nature cyclical. Nobody is in a perpetual singular mood state all of the time when they have a mood disorder. It's changing. In some cases, it can change erratically. They are fundamentally cyclical. So the result of that is that their capacity is cyclical as well. And so it doesn't even necessarily take a period of dysregulation or a symptom episode in order to cause those learning gaps. It can simply be because there is cognitive dulling that happens in the morning or in the afternoon, depending upon whether this individual is has higher energy levels in the morning or later in the day. And so it's not uncommon for teachers and parents to say, well, you could do this yesterday, or you could do this morning, you can do it now. When the truth of the matter is that no, they can't. Um, and I don't know a lot of children who actively like to disappoint the adults in their life. Kids want to be accepted, they want to be included, they want to feel safe, they want to feel loved and appreciated. And those things are threatened by symptomatic behavior. So when that symptomatic behavior happens, it's really important for us to recognize like their brain is offline. They're not going to learn anything in this moment. This relates to something that we talk to all about all the time, which is that in the moment of dysregulation is not the time to have a child apologize for something that they've done that hurt somebody else. It doesn't matter. how important you think it is. They're dysregulated. They can't do it. And so they can't learn a lesson when they're dysregulated. You sending them to their room doesn't teach them that whatever they did, they shouldn't do again. What it teaches them is that they're being socially isolated and ostracized for something they didn't have control over. Staying with them, helping them through the dysregulation, accepting them, and helping them move through that dysregulation to a place of regulation will then allow them to have their brain come back online more quickly. The longer they stay in that dysregulated limbic system state, the more likely they are to return there the next time, the more difficult it will become for them to regulate. So we have to remember, we have to do whatever it takes to get them out of that dysregulation as quickly as possible, making them feel safe, making them feel heard, making them feel validated, making them feel as though their status hasn't been um, damaged. The greatest thing I've ever seen in a school was the system of getting a kid who was dysregulated out of class and then back into class at a particular alternative school, where when the child was dysregulated, they had the ability to immediately leave the classroom. They didn't have to ask permission. They didn't have to be instructed. They didn't have to be let out, but they knew exactly where their safe space was in that building. And they knew that regardless of what time of day it was, they would go in there and there was an adult who was going to listen, accept, not judge, and not discipline. And when that child was ready to go back to class, they would be walked back by that trusted adult who would say to the teacher, so and so is ready to come back into class now. And the teacher's response was a smile, eye contact, welcome back. We're working on social studies now. Why don't you join us? People think, oh, well, they're not going to learn that they can't do that thing. They know they shouldn't be doing that thing. They can't help it because they don't have control over those symptoms. So when adults are kind, when adults are accepting, when adults listen, it is most effective at this as at de-escalating those problems.
I love that. And I think that hopefully all of us here are making these connections and understanding that this is the best and most appropriate way to handle these situations. But a question that has come in is, what if the whole family's not on board? Or what if other people aren't on board? You know, you're trying to implement appropriate strategies and they're like, this is stupid. Is it still worth trying? Similarly, you mentioned ketogenic therapy. A child is recommended to try a certain diet, but others in the household aren't doing it. Um, how do you navigate that? And is it worth navigating is really the question.
That's an individual choice that families have to make. And unfortunately, too often we see parents who are at odds with one another about treatment. Whether they're co-parenting in the same house or they're co-parenting in separate homes. The when two co-parents or additional co-parents are at odds with one another, it is extremely difficult. When they are aligned, it makes it much, much easier because then they know that there is at least going to be consistency for the child in the home. The question about what about extended family, friends, community members, teachers, and the like? For some people, that is something that they wrestle with. How do I do this if my mother, my cousin, my sister won't support me when we're together in this intervention? And there are other parents who will simply say that they don't care. what anybody else says or thinks. This is what they're doing for their child, and they're going to do it come hell or high water. It's very hard, and I'm not saying this flippantly. There's a parent in our community who often comes and will talk to our parenting class. Um, and this parent, when asked, like, what do you do about the people who don't understand, um, who 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 judge and don't offer support? And she had a very flat, matter of fact response, which was that they don't need to come to our house. If they can't support what we're doing to help our child, then they don't need to be a part of our lives. Now, she and her husband are in full agreement on that, which makes it easier. But these are extremely tough choices that families have to make. And there is no right or wrong answer. There's only what can your individual family manage and live with. And that is going to be unique to each family. But this is where I believe being able to come together in community with other families is so important, because it means that whatever it is you're facing, whatever decision you're making, whatever pushback or challenges you're getting from your network, you have a community around you that's supporting you. And so I do encourage all parents to get engaged in some form of parent community so that they can be supported and not feel alone.
Community is certainly essential. And I think that when you're working within a school system or you're working with extended family, it can get really tricky. And you do sometimes have to make hard choices. And so you can feel very isolated and alone. Um, and so having that community of people who understand is really what keeps you going. Thinking about school systems, I'm going to lump two questions kind of together. Someone is asking, what are the key components of supporting the shift away from rewards and token economy when many of the public school systems use PBIS teaching? Um, and so, what can be suggested in support of this? And then I'm going to lump in the question of, as a school psychologist, how can I support children who maybe desperately need mental health support but aren't able to get it or aren't willing to get it? So, what are some of those key supports for that for those options?
Yeah. So it's tricky, and usually my answers to these questions are a little bit controversial, and people sometimes don't like what I'm about to say. But that it's really, really hard when you're working in a system that has formularies. And that's whether you're working in a hospital system that dictates that you can't make certain diagnoses or you can't prescribe certain medications, or whether you're working in a school that has a system that has to be followed. It's very hard for individuals to be able to make meaningful change in those contexts. That said, as a teacher, as a school psychologist, as a parent, um, I'll say parents often don't realize that they have the right to say no. They have the right to say no to the doctor. They have the right to say no to the teacher. They have the right to say no to the school psychologist. That they're the experts in their children and deserve to be heard. Um, but very often, um, when we have these systems that folks are working in, you are the authority in your classroom. You're the authority in your office, in the special services department. You are the person who decides how you are going to interact with this child. And so, on a very personal level, and I've found working with families all across the country, in school districts all across the country, that that all it takes is one person who's willing to go the extra mile for that child. One person who's willing to say, I will be their safe adult. I will be the grown up that they can go to when they're distressed. I will be the person who listens. I will be the person who does not judge. I will be the person who helps them de escalate. I will be the person who shows them unconditional positive regard and acceptance. And I will be the one who doesn't give them a sticker when they do what they're told, but rather acknowledges the struggle that they're facing. You cannot underestimate the impact that that will have on a child and on their entire family. That is the difference in many cases between a child who's traumatized by going to school and a child who likes to go to school. Because when they know that they're safe, supported, liked, included, when all of those things are given to them, are a fundamental part of their understanding of the adults that they're interacting with, that child is going to be able to handle whatever symptomatic things happen better because they're not also having the problem of, oh no, now everybody hates me. Um, you know, as a parent going in and saying, like, we're not going to use the sticker chart. No, I don't consent to a token economy that is going to make my child feel like a failure. You can do that. You don't have to sign that IEP. On a more macro scale, though, we are running into more and more frequently parents having to ask themselves, is that school system where my child belongs? Is that school system truly going to be able to meet their needs? Or do we need to find something that is an alternative? And more frequently, we're finding that parents are turning away from those systems that have sort of a my way or the highway approach. It's challenging. It creates all sorts of additional logistical problems for families. But very often it's the thing that's necessary to wipe the slate clean so you can focus on the health and well-being of the child rather than whether or not they're fitting in and getting what they need from a system that wasn't designed for them.
Someone had just thanked you in the chat for your passion in being able to speak so eloquently about this in for children and families. And so I just wanted to pass that along. One
Thank you.
final question as we wrap up, because I think it's important. Someone had mentioned that they worked with parents who basically were fiddling with their children's medication
Mm.
because of weight gain or maybe some other side effects. And obviously, we know that medication can be an integral piece and typically is an integral piece of finding stability. And how do we approach parents or others who might be thinking, this isn't worth it, this weight gain isn't worth it, or these side effects aren't worth it? And I know you touched on that a little bit in um, the session, but any other thoughts on how to approach parents in recognizing that this is important and there are other ways to go about it?
Yeah. So it's a that's a big topic. I'll try to go through this sort of as quickly as possible given the time. But for starters, I would say that medications are very often integral parts of the treatment plan. They have side effects, both short and long term. And the biggest mistake that I see happen over and over again is many changes happening all at once very quickly. Parents want things to get better fast. Schools want kids to get better fast. Providers want kids to get better fast. But the reality is that we are putting chemicals into their body to alter their brain chemistry. It affects their gut biome. They are going to have impacts. And so the first thing I would say is don't mess with more than one thing at a time. You know, approach any medication adjustment as a singular task that needs to be undertaken slowly with attention, with tracking, with being able to know, is this medication treating the symptoms that it was intended to treat? Is this medication having side effects? Doing that risk benefit analysis of what is it causing and what is it curing, and being able to decide whether or not it works. The truth is that many children are given the incorrect medications. Again, I'm going to say something that's a little controversial. Pharmaceutical companies really convinced providers that antipsychotic and second generation antipsychotic medications were the first line of defense for mood disorders in children. And the truth of the matter is that they're not. There's studies that have been done on this that show that antipsychotic medication has no long-term mood stabilizing effects. It has short-term effects. What that means is that it's great as a PRN, is great for something that can stop a manic episode from taking off. But however, what it can't do is it can't by itself create long-term mood stability. And so we have to be looking at what medications are we giving, what their side effects are, and are they the right medications for what it is we're trying to treat. There are some illnesses that, yes, you will be on medication forever, just the way someone with type 1 diabetes is always going to need insulin supplementation. But there are some disorders that are being shown to be able to be treated by other metabolic interventions. And I would encourage anybody who is interested in doing that to do their research, to get as much information as they can on those impacts so that they're making an informed decision and never take away a treatment that is working without something else to replace it. Because just because we're not getting because we're not getting wet when it's raining, because we're using an umbrella, doesn't mean that if we take the umbrella away, we're going to stay dry. You can't just take away medication because it worked. You have to keep it in place for it to continue to work. So slow titration, small incremental changes, and looking for all of those lifestyle things that are going to supplement and make symptoms improve are going to be an important part of that process.
I think as we close, the piece that I really want to take away, and I've seen this session numerous times, and every time it still is mind blowing to me, is that it's not purposeful, but also that there is this array of possibility when it comes to finding stability for our children. It's that three-legged stool that's really important. Yes, medication is important, but it's not always in and of itself. We need to add in the therapy, but it needs to be when they're stable and it needs to be appropriate. And then really those lifestyle interventions are what at home we can do relatively easily without having to, have a doctor's note for that. That can make such big difference in the lives of our children. And thinking about those lifestyle interventions, sometimes there are pieces of that we can take into other spaces outside of the home that can also be beneficial. And so I think that those are really the big takeaways that I take with me after watching this session. So I thank you again, and from the chat, thanks you for your passion and the knowledge that you've shared. I think that the more people that understand this differentiation, the sooner that we can have spaces for our children with mood disorders that they feel safe in and that they can thrive in.